Cor pulmonale. Symptoms and signs of fluid overload secondary to lung disease. So there will be fluid overload. It's basically right ventricular disease characterized by hypertrophy and dilatation with or without failure. Mainly mention this secondary to disease directly affecting lungs. Now let's look at it in detail. Types. It's acute and chronic. Acute follows a massive pulmonary embolism. There will be sudden increase in right ventricular pressure. In chronic pulmonale, there will be two types: hypoxic subtype, obliterant subtype. Hypo- Hypoxic subtype associated with COPD, and obliterant subtype is associated with pulmonary thromboembolism. Causes: disease of lung, COPD, example emphysema, chronic bronchitis, pulmonary tuberculosis, high altitude dwelling, cystic fibrosis, pleural fibrosis. Disease of pulmonary circulation are the next cause, such as recurrent pulmonary thromboembolism, primary pulmonary hypertension. The other causes includes disease of thorax such as sleep apnea syndrome, obesity, disease of respiratory control such as brainstem lesion, central sleep apnea. Clinical features: the symptoms similar to right-sided heart failure, that is fatigue, syncope, dyspnea on exertion, chest pain, palpitation, abdominal distension, edema of lower extremities. Signs includes pedal edema, palpable left parasternal lift. Then we have JVP with attenuated A wave, prominent jugular V waves, which are similar to tricuspid regurgitation. There will be attenuated pulmonary component of H2 heart sound. Right-sided S4 heart sound will be heard. Ejection systolic murmur will be heard in the pulmonary area. Avert right-sided heart failure. Patient with chronic cor pulmonale, there will be increasing peripheral edema, there will be raised JVP, and there will be hepatojugular reflex which will be positive. Hepatojugular reflex is nothing but when pressure is applied over liver for around 30 seconds, it will press firmly over abdomen. Venous pressure gets exaggerated initially due to increased venous return, and the later myocardium accommodates extra venous return and level falls. When level falls within 2 to 3 cycle uh, of cardiac cycle, that is less than 3 seconds. Positive test, there will be raised JVP and it will be more than 10 seconds of hepatojugular reflex. Then we have enlarged heart, right ventricular third heart sound will be heard, right sided fourth heart sound will be heard. Investigation: chest X-ray shows enlarged pulmonary artery, right ventricular will be enlarged, distended esophagus and central vein. In pulmonary embolism, there will be wedge shape opacity, so wedge shape opacity seen in the lung. Then we have lung lobe oligemia. Then electrocardiogram will show large P wave right axis deviation. Electrocardiography will show dilated hypertrophied right ventricular. BNP, brain natriuretic peptide, is a biomarker for pulmonary hypertension in COPD. Management: the general measures will be taken such as non-pharmacological, wherein we give oxygen therapy, non-invasive positive pressure ventilation, that is continuous positive airway pressure, or BPAP, CPAP or BPAP will be given. Pharmacological, diuretic, vasodilator, anticoagulants will be given. Pulmonary hypertension treatment: restrict salt intake, digoxin diuretic. Right-sided heart failure treatment: restrict salt intake, digoxin diuretic. Then we have surgical treatment wherein we do pulmonary embolectomy if pulmonary embolism is not resolved. Then we have heart lung transplantation for primary pulmonary hypertension. And this is a summary of cor pulmonale: definition, causes, clinical features, and we have investigation and management.